So, welcome to another episode of Beyond the Pelvis. Today, we are privileged to have with us Dr. David Schechter. Dr. Schechter is a family and sports medicine physician who has been practicing for over 25 years. He has served as a clinical associate professor in the Department of Family Medicine at the University of Southern California in Los Angeles. He has lectured to patients, medical students, psychologists, and doctors around the region and nationally. He's the author of several books, including Think Away Your Pain and the Mind Body Workbook. Welcome today to the podcast.
Thank you for having me.
So I was just wondering if you can just start off by sharing a little bit about yourself, who you are today, and what brought you into this space.
It's not that unusual for people who go into the area of chronic pain and specifically mind-body medicine to have had a personal experience themselves. So my experience was my own, which was as a medical student, 21 years old, having knee pain that hindered my ability to do the two things that reduced the stress of medical school, which was running and playing basketball. And the knee pain got worse, and so I went to the student health, and they gave me some meds, and then I was referred to an orthopedist, and he recommended, some exercises and eventually a scan, and nothing really showed up that was definitive. So I spent a lot of time in the library kind of reading up, like, what can I do to get this knee pain to go away? And, get the legs strong and all that kind of stuff. And then one day I walked into the office of Dr. John Sarno. And Dr. Sarno was not yet known as the guru of mind-body medicine that he later became known as, but he was a physiatrist, a physical medicine rehab doctor at the NYU Rusk Institute. And I went in there because he had lectured to us in anatomy, and I thought he might recommend some physical therapy or something to strengthen my knees or improve my knee pain. And when I talked to him briefly about what was bothering me, he said, "I don't know how you'll take this, son, but a lot of this chronic pain is psychosomatic. I think 95% of it is." And it kind of shocked me because he was going to, knee pain, psychosomatic. So it's like a blast of cold air hitting me. But that blast of cold air kind of inspired the rest of my career to a certain degree. I subsequently was invited by him to his seminar that he gave on Monday nights for patients. And when he laid out the schema he had, this was in the 80s now, the schema of how the brain, the mind, and the emotions could cause and perpetuate pain in various parts of the body, including back pain, including knee pain, including pelvic pain. It really made sense to me, and it felt like it gave me an explanation that the other doctors had not really provided, a more integrative, a more holistic, an explanation that made sense in my context, the context of being kind of a stressed out, not that happy first year medical student, which is pretty common when you've come from college to a lot of memorization and things that go on in the first year of medical school. And so when I went home that night, I had an interesting experience. I sat down on my bed and I felt like a weight was lifting off of me, like a pressure was lifting off of me. It was really interesting. And I just felt lighter. And then as I'm walking over the next few days, I felt like I could move a little better. My knees weren't quite as distressing. I went to see him for examination. I went to another one of his seminars that he offered. And I began to shoot a few free throws and then do a little jogging. And, before I know it, I'm back to activities. It was really a remarkable recovery that I was just amazed that educational materials and a diagnosis, lectures, could make that much difference in pain that had been really persisting for months. So that's how it started. And then I did a research study with him the following summer. I got a grant and was able to spend time in his office, see patients with him, and then call up 175 of his former patients, hearing the same kinds of remarkable turnarounds from people with back pain, neck pain, knee pain, pelvic pain, all kinds of pain, using the same approach. So it wasn't just me that had been benefiting, but it was like, wow, a lot of people out there benefiting that I compiled that data into a study that he used for one of his books, and went on with my medical school training and did a residency program in family medicine, certification in sports medicine, but always kept in mind that I wanted to really work this way, and had an opportunity many years later, now we're in the 90s, to reconnect with Dr. Sarno over a project that someone else had proposed. And he was now pretty well known because he'd written a couple of best-selling books. And he said, "I'm getting a lot of patients wanting to see me, wanting to know if anybody does this work. I don't know anybody to refer them to. You're in California. Can I refer to you?" And I figured, how many patients am I going to get referred from New York to California in the 90s? Remember, there was still no internet yet. This was the early, mid-90s. And lo and behold, the phone starts ringing, right? And I start getting patients. And then once you have patients, you can really learn how to work with the individual patient's needs. And that has comprised the last 30 years, where I've seen over 4,500 patients with chronic pain and published some studies, written some books, and taught a lot of other doctors and psychologists about this approach as well. That's the story.
Wow, that's so interesting. I am curious, what was it? Because people are familiar with TMS or mind body, right? It's like
Yeah.
trapped emotions or a certain type of personality. What was it in you that was causing your
That's a that's a very good question. See, I don't, I mean, look, I may have come from a little bit of an anxious family, but I don't think this was childhood trauma. I think this was personality driven, meaning, hard on myself, worrier, in the context of I've gotten into medical school. Boy, I'm not really enjoying it very much, right? It's like not fun. And when's the good stuff going to come? When am I going to see patients? When am I going to do that? And then I moved from New Jersey, from suburban New Jersey, a beautiful campus looking out on a soccer field, to an apartment looking out on a brick wall in Manhattan. Because when you're a medical student at that time, they didn't have enough dormitory space for the so-called local residents. My family lived in New York City, but not really locally. But they didn't have enough dormitory space, so I had to find an apartment. It was a scramble. It was a renting a room from an artist. It was not the most beautiful room, and we looked out on a brick wall. So think about, like, it's like going from, heaven to prison. I mean, you compare a college in suburban New Jersey looking out on a soccer field to an apartment looking out on a brick wall. And then when you go to work or you go to school, you're learning a lot, and you appreciate that you're learning a lot, but you're also like finding it to be pretty mind stultifying, multiple choice tests, that kind of thing. That's kind of was the first year of medical school in those days. So that's what it was: personality plus context. It wasn't repressed emotional trauma from the past, and that's why I was able to get better a little faster than some patients do. Everybody has their own path toward healing, and if we talk about that, there's no guarantee that anybody I work with or anybody that uses this approach gets better in a few weeks like I did, or even a month. I mean, it usually takes longer than that, but there's usually more work to do. Also, at 21, you have a little bit less, you have less history, you have less stuff to go on, right? I mean, I wasn't married, divorced, or anything like that at that point. So life was simple. I'm not divorced now either, but I mean, that's just throwing that in there. Life was simpler. It seems simple. It doesn't seem simple at the time, right? When you remember, picture back to when you're 21, it did not seem simple. But when you look back now, it seems simpler than it is now.
I would definitely say so. It's so interesting. I'm a somatic experiencing practitioner and a breathwork facilitator. And one of my clients the other day asked me, do I need to do breath work to get better? And I said, absolutely not. Everyone's path is different. For me, it was somatic experiencing and breath work and the education that
Yeah.
you got from Dr. Sarno's thing. So it's interesting just how everyone has to find their own path and what brought them to the pain and what the pain is here to tell them.
Yeah, the pain is definitely here. The pain is a signal, but it's in many cases not a signal of damage. It's a signal of something else in the mind and the emotions. So that's definitely something that you have to work on uncovering. And I definitely agree with you that the path for people is different. I try to prescribe an individualized path, but even that individualized path, people are going to take different elements of it. Like, I'm a big advocate for journaling, which is expressive writing, which is writing about your feelings. And I've written a couple workbooks where there's prompts, and there's a method to doing it, and there's a system and all of that. But there's some people for whom journaling isn't as effective as other things. So I try to work flexibly with people and be a guide on their healing journey, but understanding that everyone's journey is a little different.
Since you brought up journaling, I thought that was very interesting when I saw that on your website. I mean, you don't have to go through like the entire book or the entire process, but what are some things that people can do easily and quickly about how to use journaling to overcome chronic conditions?
Well, let's think about this first in the sense of what does a person do after they leave Laura's meeting or after they leave your session? If you see them once a week, for example, and maybe you see them more than once a week, that still leaves 6 days a week where they don't see a practitioner or don't have interaction with someone who's really knowledgeable about this. That's a lot of days, that's a lot of hours. So one of the things that I found early in my practice was I wanted to give people assignments to do things so that the work became part of their daily life and existence. And so journaling was a great thing for that. It's also an action you take. And I find that transitioning somebody from a passive victim of pain to an active participant in a healing journey is very important. So you're an active participant when you sit down with a notebook or you sit down with one of my workbooks and you write about your feelings. So the idea of the journaling is not to write about the day's events or I went shopping at Ralph's or Trader Joe's or wherever you have in your area. It's really more about I got upset at the clerk at Trader Joe's, or I got angry at my significant other, or I was upset at school. And you write about those things. You just kind of let it flow. And it's a way of kind of like self psychotherapy, right? It's a very inexpensive way of getting at some of your emotions, learning about them, expressing them, and releasing them. And so that's something that I encourage. It takes 10 or 15 minutes a day. I mean, I've seen people do it in as little as 5 or 8 minutes, and I've seen some people who love it do it for 30 minutes. But some degree of journaling, some type of journaling, most days of the week is a really effective approach to mind-body problems, in addition to other things that the two of you might advise, and in addition to other things that I advise, which might include reading books, watching movies or apps, and you know, changing your attitude. That's the key thing, right? Changing how you think about this.
You said something that I thought was so important. You have, or we as people that have had chronic pain, have power in this journey. And giving them assignments or giving them something to do to show them that they have um, some control in how they handle the situation and the pain they're in right now. So having power in this, I think, is really an important thing.
Yeah, anytime you're a patient, and even doctors and therapists and uh, the like are sometimes patients, and you also hear from your patients that being in that patient role, you kind of get jostled around. You know, you have an appointment and you're going to another appointment, and one person tells you one thing, another person tells you another thing, and it can feel very much like you have to passively sort of do what people say. In addition to that, with regard to chronic pain, many of the treatments are either take a pill or get a shot. Those are also passive treatments. So what we do in the mind-body space, and what I believe you do also, is to activate the patient, to empower the patient, to get them doing things, right? So physical activity we can talk about a little bit and how important that is in the recovery process. I call it graded exercise because you start not with a grade of ABC, but you start slowly and build it up slowly. And journaling, again, something you can do yourself. Nobody has to see what you write. It's not a performance. It's not a pressure thing. It's just a release. Whether you do breath work, meditation, all of these things are things you're doing on your own, and getting back the power that you mentioned, it can be lost as a patient in the healthcare system.
Yeah, is as a physical therapist, home exercise program or HEPs is just part of physical therapy. And how I try to phrase it when I'm working with people is this isn't like your homework, like this must be done and it's going to be graded. I consider it their self-care program. Like, what do you need to do to take care of yourself? Is it movement? Is it breath work? Is it yoga? Is it dancing or journaling? Whatever it is, we kind of
Yeah,
come up with what that individual person needs, like what sparks joy for you, and let's find ways of doing more of that so you can focus more
yeah,
on to shift them from that sympathetic to parasympathetic, and that over time, as you know, will
right.
increase
So
your
your audience probably knows that sympathetic is like fight and flight, and parasympathetic is like relax and ease.
yeah.
And I like your concept of self-care. You know, that's something that I mentioned as well. I mean, I believe there's some necessities that people have to do that may not be perceived as self-care because sometimes they require a little effort, like reading a book or maybe writing in a journal. Sometimes that's self-care for some people. Other people, it's more of a task. But I really like the idea that people shift from many of the patients with chronic pain are responsible for others and taking care of others. And that's great. That's why they're often very nice people. But you also have to think about self-care. What do you need? Do you need a massage? Do you need a swim? Do you need getting your hair done or your nails done or buy a new a jacket or a shirt? And so think about whatever self-care means for people. It means different things for different people. Sitting for a few hours and watching a ball game or a movie might be something that people haven't done in a long time because they're taking care of other people all the time. Or so self-care is an important part of the healing strategy, and I totally agree with you on that.
And then what are some of the conditions that you have seen? How does it show up in people, this mind-body condition for you? What have you have seen?
Yeah, so I've seen so many. It's like it's almost sometimes hard to list, but I mean from head to toe. I mean, I've seen headaches. I've seen dry eyes sometimes be a mind body. Not everybody's with dry eyes, but some people with dry eyes. I've seen neck pain, usually more of the musculoskeletal kind of neck pain, trapezius neck. Um, I've seen some shoulder issues be mind body, although again, they can be biomechanical as well. Tennis elbow, again, can be overused, but I've seen sometimes it lingers and it ends up being more of a mind body thing than not. Um, going to the chest and abdomen, there's times that people have chest pain. It's been ruled out, not cardiac, they've seen the proper doctors, et cetera, and still have chest pain. And you start talking to them, and it's tension in the chest more than pain, and it's really due to stress. Of course, I'm not telling people to self-diagnose that. See a doctor first. Abdominal pain and IBS, irritable bowel syndrome, can be mind body as you work your way a little bit lower. We're talking now about pelvic pain, which is your specialties. A variety of pelvic pain in women, men, can be mind body. Now, there's several markers that I might look for. So one would be failure to respond to conventional treatments, because many people with conventional treatments get better. They don't need to see me, right? Um, the other thing would be persistence to the pain more than 3 to 6 months, because we know a lot, and we can discuss a little bit. We know a lot about the difference in the physiology and the neurophysiology of acute pain, which is like a week, 6 weeks, versus chronic pain, which is like 3 months, 6 months, a year, 2 years. So the chronicity is definitely something that marks the conditions that I talk about, and then your personality type. So we have what we call the type T personality, and many of these characteristics are something that you're probably aware of as well. It would be like a hard on yourself, self-critical, could be a people pleaser, sensitive to how others perceive them, highly responsible for self and others, sometimes a perfectionist, and a perfectionist in a way that doesn't feel good. There's people who are perfectionists because they love it, and there's people who are perfectionists because it kind of like makes them less anxious, or actually makes them more anxious. But those are some of the main characteristics. There's a few other ones as well, but the type T personality. So in the context of the personality, the chronicity, and these various locations of symptoms, it certainly did not give an exhaustive list, but I mean, I gave a pretty comprehensive list of some of the common ones. I've seen a lot of arm overuse syndromes. There was a period of time where a lot of people were saying, "Oh, I'm keyboarding too much, and I can't function. Like, my arm doesn't work." Some of the people who are diagnosed as RSD or CRPS, complex regional pain syndrome, can actually benefit tremendously from a mind-body approach, as can some people with thoracic outlet syndrome, for which there are true structural thoracic outlet, and there's many people with more of a muscular tension thoracic outlet that can respond to mind-body. So there's a lot of conditions, and I'm sure that you've seen some as well, in addition to pelvic.
So you mentioned pelvic pain.
Yeah.
So I'm just curious if you can talk a little bit more about pelvic pain, if you see a lot of patients with that condition, and maybe some of the causes, and if it's different than these other conditions.
Well, pelvic pain I see quite frequently. I wouldn't say it's the number one, but it might be the number three in terms of frequency. And typically, these patients have seen one or more gynecologists if it's a woman. They've typically seen one or more urologists if it's a male. And they have often had scans, which might include MRIs of the pelvis in some cases, or nerve testing. They've often had treatments, which might include injections, medications. In some cases, they've had pelvic floor PT. In other cases, they haven't had it. Many of them have had it. And the issue is that, the pain keeps coming back, or it doesn't go away. And maybe people haven't asked them all the questions that I ask. Again, I think pelvic floor PTs in general are more holistic than probably almost any other specialty in medicine. But I sit down and I really get into that psychosocial history. What was your childhood like? And I pause and I wait, and I want to hear a little bit about their relationship with their parents. And I want to hear a little bit about childhood traumas. Obviously, a small percentage of those, although not an insignificant percentage, there could be sexual traumas as well, sexual abuse. Could be from a relative, could be from a stranger, might have occurred in childhood, might have occurred in teenage years. So that's something we look for, but you don't have to have that to have a chronic pelvic pain syndrome. Although if you have it, it definitely needs to be addressed again if it hasn't been addressed before psychologically. And then with men, I often look for a history of guilt or adultery or affairs, and that seems to be a common issue. Sometimes there's other issues. Sometimes there are religious conflicts where somebody was brought up a certain way, but now is more sexually active than they had expected to be, and there may be some conflict with that. So, it's really about sitting and getting to know the patient a little bit. And this is what if it takes a little bit of time. That may be one reason I'm trying to understand why the healthcare system doesn't do more of what I do that is effective. But some of it maybe you have to take the time. Reimbursement in healthcare tends to be more focused on procedures and doing something to the patient rather than sitting and listening. Although an experienced clinician learns a lot from sitting and listening and asking questions, of course. I'll also, examine people. So the men, I'll typically do some degree of a genital or pelvic exam or prostate exam, depending on how recently they've had it by other specialists. With the women, I don't do that because they've had enough of those already, and I don't consider myself as expert in that, although I was trained years ago to do pelvic exams, but I don't do it anymore. But they've had that multiple times. I do look for tender points. So one of the things that Dr. Sarno noted, and it's in his books and it's in my books, is that people with these chronic pain syndromes that you call TMS, tension myoneural syndrome, or we're calling it neuroplastic symptoms or neuroplastic pain. It has a few other names that we could mention, mind-body syndrome, et cetera. But people with this condition often have 3 or more, or at least 2 tender points of the 6 on the back that have been identified. And it's in my book. There's a nice diagram. It's in my blog on my website, so you can find it there for free without looking at the book. But it's the top of the trapezius, the sides of the lower back where the QL, the quadratus lumborum muscle is, and the upper outer gluteal. And Sarno noticed that these were marker spots. So these don't necessarily have to be areas that you're having pain in, but these areas seem to be more tender in people with these mind-body chronic pain conditions than in the ordinary patient. And similarly, if I take that same patient and I press on the back of their hamstring, they don't feel tenderness. But if I press with the same 2 or 3 pounds pressure in that upper gluteal, they often jump a little bit. So there's something about those spots, and they're different from the fibromyalgia spots, although there is some overlap, and they're helpful to me as a doctor to examine. And so Sarno would say to me, you don't have to have those spots to have the condition, but it's certainly helpful diagnostically. I also think that as a physician and as a physical therapist, if you're going to do a mind-body approach, I think patients still need that validation that you're like a doctor that can examine people, right? So if they come in with back pain, I'm checking reflexes and sensation, even if they've had it done 10 times before. I'm doing an orthopedic neurological exam because it's back pain or sciatica. If it's pelvic pain, I'm either doing a pelvic exam like in a man, or I'm doing the tender point. So I'm at least touching the patient, right? I think it's important that I've had patients come to me, not necessarily with pelvic pain, but with other conditions, and they say, "Oh, you're the first doctor that's examined me." And I'm thinking, what's going on here in this medical system? Like, they get lab tests, they get MRIs, and they never actually examine the patient. Like, that's the first thing you do after taking a history. And again, we have tools now that are more advanced than listening to the heart, but you still listen to the heart, and then you get the echocardiogram, and you kind of, so I think it's all part of the relationship with the patient, and it's part of the doctor-patient experience. But anyway, I went a little bit off board on that, but that gives you just a general idea of the assessment of pelvic pain and how I start out with patients with that.
Yeah, I notice in my practice as a pelvic floor PT, those tender points as well, like I'm looking at like the hip external rotators, like they
Yeah,
all jump off the table when I touch that, or the QL. And yeah, I am also looking for like, how is your stress today? Like what's stressing you out today? And also like, tell me about your past. I just had a recent patient and she had lots of symptoms of her vagus nerve just not really doing what it was supposed to do, a lot of abdominal issues and pelvic issues, pelvic pain as well. And I was like, tell me about your childhood. And she was like,
yeah.
I had a narcissistic mother. And I was like, well, girl, there you go. Like,
Yeah, people need to know that that's important, right? So you put it in a context of why you're asking this. You're not asking this to be nosy. You're asking this because this is important.
Yeah.
And I think your audience probably knows the vagus nerve. We're not speaking about Las Vegas. We're speaking about VAGUS,
Yeah.
the nerve that kind of controls the parasympathetic system, and which is that relax and ease and digest, and also works in the gut and slows down the heart and all that. It does a lot of good things for us, but it has to be in balance, right? Because if you need energy, you might need more of the sympathetic nervous system, but if you need to kind of chill, you need more of that vagus VAGUS nerve to activate. So yeah, so you're doing a lot of the same things, which is great. And it's really important. I know more PTs are starting to learn this. There's some PTs in Australia and New Zealand have pioneered a lot of pain neuroscience education. I think that the school of thinking that I come from, the Sarno mind body TMS approach, is probably the most psychologically focused, which just doesn't mean we ignore the body, but it's we believe in the pain neuroscience education, but we also believe in the underlying emotions and feelings and how important they are and methods to release them. So it's all good. It's all healing.
So we met at the PPDA conference this September, and it was
Yeah,
such a pleasure to meet you. And one of the reasons I wanted to have you on the podcast is because I've met many practitioners and I asked them about PGAD specifically. And you had said to me, "Oh, yeah, I've seen patients with this."
yeah,
And I find it, and I have clients with this as well, and I find it, you know, a really tough diagnosis for
yeah.
a lot of women and men to get because it can be embarrassing.
Mm.
And it's very, it's vulnerable to talk about. So I was wondering
Yeah.
if you could talk a little bit about that and what you've seen with
Okay,
this.
so just PGAD, persistent genital arousal disorder. And first of all, if anyone in the audience is listening who has that, I just want to express my empathy. I mean, it's a real condition. It's a very troubling condition. It's a very sort of disordering the nervous system type of condition. I totally give you my respect and hope that you improve. So I want to just validate that condition. Um, Unfortunately, it's not widely known by many physicians, although there are some that specialize in it. And as you said, there seems to be a stigma because you're talking about genital arousal when so it's not something you can talk about your back pain with your friends, but you probably don't necessarily want to talk about your PGAD with anybody other than a very close friend or significant other or something like that. So it does make it's isolating. It's difficult to have this. So the approach that I would take with this is first of all validating the reality of it, as I have done in my open remarks here, and then I would just talk to people about like let's figure out and I would take the kind of history that I do in terms of the childhood and adolescent experiences and sexual experiences and this and that. And in no way am I saying that they are the cause of the problem, but with all of these conditions, I say to people, it's not in your head, but we can use your head to make it go away, right? So it's not imaginary. It's real discomfort, real disorder, real distress, but we can take advantage of the fact that the body is wired from the top down, not just from the bottom up, right? So bottom up would be that pelvic floor manual therapy kind of approach or physical therapy to the back or neck. And top down would be education, psychology, input in that regard. And then that affects the nervous system through the spinal cord and the various nerves, including the vagus nerve and the nervous system in general. So I try to give them hope that taking a different approach that maybe acknowledges the reality of this, but at the same time says, let's see if we can find a way to calm the nervous system. Let's see where your stressors are coming from, both in the immediate, near term. I try to look at when the onset of this was. The onset often tells you a lot. So if your pelvic pain or your back pain started after a divorce, I mean that's probably related to that relationship. If it started after the loss of a spouse, a loss of a parent, it could be related to grief. If it started after you were treated abusively at your workplace, it might be related to that. So you want to see the onset of the symptoms, and at the same time, you want to understand the milieu, as we call it, the context of that, which is like the personality. What's your personality like? Getting back to that type T with the heart in yourself, perfectionist, people pleaser, highly responsible. And then we're just working on methods to to just kind of gradually look for progress, right? So we're going to do a little journaling, we're going to do a little breathing. We might try a good therapist who's comfortable with mind body issues and pelvic pain and PGAD, and we're just going to kind of work together, try to develop the right team, the right approach. We're looking for incremental progress. This may not flip off like a light switch, but if we can get it from 8 or 9 out of 10 down to 6 or 7, and then we can get it to 5, 4 or 5, then your life is much more livable or manageable, right? And our goal is to get it to go away completely. My treatment approach is pain recovery, not pain management. But sometimes with like a condition like PGAD, you have to start with just kind of modest goals initially. We'll work together. We'll get you more comfortable with the team approach. Maybe you're working with a pelvic floor therapist as well. That's fine. If you're not, we could think about that, or we could, if you want to take a break from that, that's fine also. So there's just different ways to work with the person. I'm in California. I have a lot of good therapists that I know who are MFTs and LCSWs and PhDs. Also know a lot of TMS coaches who are much less limited by state licensure and things. Obviously, I think that Laura kind of falls in that category with her somatic work as well. And so there's TMS coaches, there's therapists I know in other cities, there's some physicians I know in other cities, wish there were more. Some physical therapists are doing this work as well. And so putting together the right team, I try to individualize that team for the patient's needs, and I collaborate. I work with that team. I don't just like refer you off and then never see you again. I want to follow up. I want to see what help I can provide. And I've had success. I mean, I wouldn't say that it's like a light switch kind of a thing. I mean, I've had people who've had back pain for 20 years, and some of them take 3 months to get better, 6 months, and some of them get better in a week. It's kind of a stunning, shocking thing. PGAD tends to take a little while to work on. But with the right integrative method, a lot of the things we've talked about today, there's hope. And if you're not incorporating the psychological parts in a powerful way, or you are incorporating the psychology, but you don't feel your psychologist is focused on recovery, maybe they're just focused on management, then think about getting to someone like Laura or myself that can get you to people who, or be people that can work in that regard.
I think you brought up a really important point, the difference between like managing and treating or
Yeah,
curing. And
yeah,
because I feel like, even as a physical therapist, like we have to be so careful to talk about cure or healing, right? Like that doesn't
right.
happen. We don't want to give false hope where it's like, but maybe they do need that hope because I have had patients who've had years of chronic pelvic pain and then it's just gone in, a few weeks. And
Right. Well,
that's not
if you think,
managing.
I mean, how many patients do you talk to who are 70 who have chronic pelvic pain? I mean, fortunately, not too many. So if they had it in their 30s, some
Right.
people must have had it in their 30s or 40s. It seems to go away at some point. Now, that doesn't mean you have to have it for 30 years. I'm just saying that there really is hope that pain can be recovered from and healed. And I know that there sometimes, as you said, in different disciplines. So pain psychology is a discipline where many of the people trained are trained to, if you will, shave 10 or 20% of the pain off the top rather than cure the pain.
Yes.
Physical therapists have to be careful with their language because of their licensure. They're not supposed to diagnose. They're not supposed to, promise prognosis, whatever. But as a healer physical therapist, as a healer coach, as a healer doctor, if you don't shoot for recovery, you can never get recovery,
Yeah,
right?
what are
If
you
you don't
doing?
shoot for the moon, you're not going to make it. If you don't shoot for Mars, you're not going to make it to the moon at least, right? So you have to kind of sometimes shoot farther. And if the person gets 85% better, they're going to be an appreciative patient forever. If they get 100%, then it falls into that, hey, that's fantastic. I'm so glad that you completely recovered. I'm here if you need me kind of thing. So I try to shoot for, I try to not give false hope, but I try to give hope. And I try to explain that I've had successes and that I can't promise how far you'll get along with this, but let's take it month by month, week by week. Let's just see how far you can go.
Yeah.
And so there is hope.
Yeah. I do the same as a physical therapist too. I mean, I feel like I am um more rebellious in that way where I will explain like here is what is expected, but
Yeah.
here's what I'm expecting. Here's what I have seen. Here's what I've heard happen to other people. And, there are times where I do have to separate, like, okay, this is the physical therapy and this is like the healer in me. And that's why I do offer, yoga and I have training certifications in yoga and meditation and all different things because it's like sometimes we have to step away from physical therapy because there's this expectation, right? Of like, okay, we're managing the pain or let's learn how to compensate where I'm like, no, let's not. Let's actually get you feeling better and get you back to being like a whole person. And that's when I will step out of the PT role and into the more healer role because I want to see them thrive and be well.
Yeah, and like you mentioned with yoga and other things, I mean, some of those things like home exercise program, those are things that people can do on their own as well as with you. And so it really is empowering, right? So it's not just about those wonderful sessions with you. It's also about, because ultimately my goal is to have the patients be independent of me and not see me for this. I mean, I'm always available if it comes back, but I'm not a doctor looking to just give them 3 epidurals a year and then that's like a success. I don't consider that a success. I don't do epidurals. I do other kinds of shots if needed, but um, that's not a success to me. A success is you don't need to come in for epidurals.
Yes.
You don't need an invasive treatment. You don't even need physical therapists, although it's good that they're there because everybody gets injured sometimes. I go to physical therapists when I'm injured or I get a massage or whatever, body work. But that's for acute pain. So the most effective types of physical treatments are for the acute and subacute pain. And when someone moves into that chronic pain area, we just have to think about this differently. It doesn't make sense to treat a different condition with the exact same approach that we take with the acute and subacute pain. And unfortunately, that's what a lot of healthcare has mistakenly done. Um, I don't want to criticize any one particular profession, but it seems sometimes like chiropractors treat an acute back sprain the same way as they would treat someone who had 2 years of chronic pain, right? And to me, it's not the same thing. So it doesn't make sense to keep doing the same thing with that. And there's other fields that maybe also haven't mastered the adjustment between acute and chronic pain.
Physical therapy, I would say, falls underneath that category as well. And even though you mentioned like some physical
Yeah,
therapists, coming out of Australia and New Zealand, like they're kind of leading the way in
yeah,
talking about pain, like how to actually help cure pain. But there's still a lot of what I call cookie cutter PT happening in this country, in the US, where someone has chronic back pain, they give them the same usual
yeah.
back exercises to strengthen and ice and e-stim and they're not really getting to the core of what's actually going on. And that's probably one of the things that sort of made me start to question, even back in PT school, like we're talking a whole lot about chronic back pain, but what are we really doing? Are we getting to the core of it? And it wasn't until I started learning um, about and making the connections even between like the chakras that are in yoga where people hold and store emotions where I'm like maybe there's something actually there and then realizing oh there's this whole like TMS thing and
Yeah.
it could be stored emotions that people aren't releasing or letting go or chronic stress that they're holding on to and we've brought up on this podcast before like the body keeps the score and
Mm.
that's one of those examples. I mean there's so many, you listed all of them. We've
Well,
crossed everything.
it's great that you're an individual who was trained in the conventional method, but you were willing to look out beyond the box, right? You were willing to think about other options. You're willing to ask questions. And it seems to me like, unfortunately, a high percentage of people trained in the American healthcare system just want to do what they're comfortable with. They want to do what they were trained in. They want to do what they did in medicine, like in residency. Like that's the way I learned in residency, so I got to keep doing it that way. Wait a second, things have changed since you were in residency. Things have changed since I was in medical school. Things have changed since you were in PT school. But it seems like it takes people willing to think outside of the box. Now, I'd like to teach more people to think outside of the box, or I'd like to make this stuff that we're talking about today in the box. So it
Exactly.
doesn't have to be considered out of the box to do it. It's like, oh yeah, like I do this, and then I move on to TMS and neuroplastic pain. It's like it should become a clear part of the guidelines and the protocols. And fortunately, there have been some of my colleagues, and this was discussed at the course, doing research, publishing papers. This is the beginning of hopefully more published research confirming the efficacy and effectiveness of this approach. And that's necessary and helpful. And more practitioners like you and others who are trying this and saying, hey, this really works. Let me try this. It may be a little different. It's not exactly the way I was trained, but it's really important and people get better.
And it's so important to spread the word to doctors because you mentioned before hope. And giving people hope is so important. I will have a consult with someone and then
Yeah.
they'll book an appointment a week later. And the first thing I say, how have you been since we spoke? And they say, Laura, it's so weird. I've been feeling a little better. And I didn't do anything in this consult
Yeah.
except get to know them a little, but I gave them hope. And the power of words, especially from a
Mm,
doctor,
mm.
is invaluable.
So important. I mean, prior to 1930, 35, when antibiotics were first invented, that's almost 100 years ago, 90 years ago, pretty much everything doctors did was a placebo. It was a hold your hand, look at you, you're going to get better. It's probably will take a few weeks, maybe we'll try a tincture of this and a tincture of that. But mostly they didn't have therapeutics that were effective. And then over the next 30 to 50 years, Western medicine advanced dramatically in antibiotics and heart surgery and renal dialysis and all of these miracle things that keep people alive. And somewhere along the line, doctors and other practitioners in healthcare, I'm just kind of using the generic doctors. You're a doctor of physical therapy too. So um, lost the ability to communicate with patients. And half of what I see, I'm like a deprogrammer because half of what I see is the doctors are giving people nocebos. You may not have heard that term in the audience, but the opposite of placebo, which is an inert substance or a message that helps to heal, a nocebo is an inert substance or a message that actually hinders people from healing. And every week, and I gave a lecture at a physical therapy clinic recently, and it's not the first lecture I've given to that group or to groups of physical therapists. And I was talking about some of the statements, some of the nocebo statements, and I write these things down when people tell them to me. One doctor told his patient recently, after looking at their MRI before even examining them, I'm surprised you were able to walk in here today. I mean, what, come on. I mean, how can you be that dense to say something like that? And by the way, the person walked in perfectly well that day. So you have to really know how to talk to patients, right? In a therapeutic manner. That doesn't mean hiding things from people, but that means giving hope, as Laura mentioned. That means, opening up the discussion to their lifestyle and their psychosocial situation, their stressors, and certainly not saying things like, I can't believe you walked in here today. I mean, your back is the worst I've ever seen. I mean, I have a whole list of these. I've written so many of these phrases down that are awful. I'm sure as a physical therapist, your patients have shared, oh, yeah, my orthopedist said, I'm going to definitely need surgery in 5 years. Like, what are they, prophets? They know the future. I'm definitely going to need something. Who knows what's going to happen in 5 years? Nobody knows. I find that frustrating. I'm glad you brought up that language as being so important.
I feel like healing starts, and I think we've talked about this on this podcast at least, like healing starts for me at least with the consult, right? Because I give them that free consultation, I allow them to share what's going on,
Uh-huh.
and I tell them my approach. Like if you are open, I can help you. And then when they come in, or now I go to them, but even when I had an office space, like I was so intentional about my
Mm.
space. Like it was a healing, welcoming space. The lights weren't like glary and uncomfortable. We talked about lights before. And I would have music playing or like soundscapes going.
Yeah.
And I was so conscious about the language that I used because I didn't want to say something that might trigger them or they would take it as, oh my goodness, nobody can help me. Like I
Yeah.
was so careful with my words. And yeah, you mentioned the nocebo versus placebo. It's so important. And yeah, it just needs to be part of everyone's practice. PTs, chiropractors, just anyone who works with people when dealing with chronic conditions. It should
Hmm.
just be automatic that we just assume this is chronic. Let's take the mind body approach. It's chronic.
Yeah.
Like,
Yeah.
why else would you not do that?
Totally agree with you.
And there's nothing to lose by having the mind body approach. You know, taking the time to address some of your limiting beliefs, your self care is never going to hurt the person. That doesn't mean we stop going to doctors and always take this mind body approach. I tell my clients, please, see doctors if we need to,
Yeah.
but there's never a loss of trying this approach.
Well, patients are still stuck in what I think was true probably 40 or 50 years ago, which is at that time, it was very easy to miss illnesses, miss diseases. Now the imaging and lab work is so sensitive that we're actually more likely to find things that are irrelevant, that are equally present in the asymptomatic, that are gray hair of the spine, that don't mean anything. And so people worry, oh my God, they've missed something. But no, it's probably they've seen more than they need to see. It's not that they've missed anything. And yeah, so Laura, once they've done that testing to make sure that your abdominal pain is not a tumor and your pelvic pain is not a infection and your back pain is not a massive massive herniated disc or something else, once they've done that testing, move on. I mean, this is if you're not getting better, it's probably because you need to move more and you need to think differently and you need to process stress better. It's not because you need more tests or more examinations.
Thank you so much. This has all been great, great information. And I feel like we could keep talking forever, but it would be great if you can share where people can find you because I know you do have a lot of resources available.
Thank
So,
you. Thank you.
yeah.
Well, my website is mindbodymedicine.com. So that's a pretty good place to start. My practice is in West Los Angeles. I'm not able to do video visits out of state for the first visit. If you're visiting California, I can do a video visit while you're visiting. If you're visiting Los Angeles, you can come to see me in person. I've written a number of books. They're all on Amazon, Audible, and Kindle. And I've written a number of books, workbooks. I have an online course, which can be linked from the website. We're currently offering a 50% off Thanksgiving Christmas sale on the online course. It's a 5-hour video program that really explains this material in great detail, but you can also start with the book. You can start with the website. There's free materials on my website as well, like podcasts and other things you can link to. Maybe I'll link to this podcast at some point once I get the link. And it's you start with learning. You were mentioning, Dr. Siegel, that that it starts with the appearance of the room and the vibe in the room and all of that. But I would say for many people now, it starts with the appearance of the website, or it starts with the messaging that they're hearing on the website and stuff. So it's like, right? I mean, I have people come in who've read one of my books in advance or one of Dr. Sarno's books, and like they're already 10% on the healing path, right? So I've got to just keep them going, and that's kind of exciting, and keep it going along. So. It's pretty easy to reach me, and I'm sure they can post things on their podcast page or whatever in addition. But maybe I'll hear from some of you, and if you read my book and it helps you, let me know as well.
Great. Thank you so much.
Well, I've read your book, Think Away Your Pain, and it's very good. So I hope anyone listening that hasn't read your book will pick up a copy or listen to a copy. So, and thank you so much for being here with us today. We really appreciate your
You're
time.
welcome. You're welcome. And I can say Happy Thanksgiving, even though you can delete it if it turns out you're posting this 3 weeks later. But anyway, happy holidays, happy Thanksgiving. Take care.
Thank you.
Thank you.